Okay, a very good morning to everyone. So, today the study that we will be talking about is on the knowledge of Anganwadi workers on maternal nutrition, evidence from Sultanpur district of Uttar Pradesh, India. So, I'll just give you a brief introduction about what the study is all about. Maternal nutrition is a critical determinant of pregnancy outcomes. Majorly, mental health and child survival are dependent on it. So, recognizing this, the government of India
Ma'am, I
has
think your
implemented.
network is not stable.
You can't hear my voice.
Ma'am, the voice is little breaking.
The voice is breaking. Just a second.
The voice is okay for us.
Okay, you can hear the voice. Okay, should I continue then?
Yes, ma'am.
Okay.
Yes, ma'am. Yes, ma'am.
So recognizing this, since maternal nutrition is a very important determinant of pregnancy, so the government of India has implemented several initiatives, including the Integrated Child Development Services, the Poshan Abhiyan, National Nutrition Mission, under the National Nutrition Mission, and Anemia Mukt Bharat to improve maternal nutrition and overall child health outcomes. So within this framework, the Anganwadi workers who are functioning under ICDS, they are the backbone of community-based maternal and child health services. Now, despite the implementation of comprehensive national initiatives, like I just talked about the ICDS, Integrated Child Development Services, the challenges
Sorry to
related
interrupt,
to
doctor.
malnutrition.
Can you please
uh,
share your presentation? PPT.
Yes, my research scholar Sneha Srivastav is sharing the presentation. Sneha, have you shared the presentation?
We can't see the slides.
One second. Sneha, actually, due to some technical issues, now I'm not able to share the presentation with my phone. So she is also presenting along with me. So I requested her to share the presentation. Yes. Now, can you see the presentation?
No, we are working on it.
Okay, ma'am, just a second. She's sharing the presentation.
You can
Okay, is
start, ma'am.
the okay. I should be, begin from the beginning.
No. If you can tell me which slide you're on, we'll move the slides.
On the third slide
Okay, then.
after this. Yes, this one. So I was just saying that despite the implementation of comprehensive national initiatives like the Integrated Child Development Services, the challenges related to malnutrition, anemia, and inadequate dietary practices among pregnant women continue to persist, particularly at the community level. However, the effectiveness of these programs largely depends on the knowledge, attitudes, and practices regarding maternal nutrition among the Anganwadi workers. Now, therefore, keeping this in mind, it becomes crucial to assess and strengthen the capacity of the Anganwadi workers to ensure the optimum program implementation and improved maternal and child health outcomes. So, this justifies the need for focused research and intervention in this area. Now, we have chosen the study area, Sultanpur district, in Uttar Pradesh due to the existing gaps in maternal nutrition awareness, limited accessibility to health and nutrition resources in several rural and underserved areas, and the need to strengthen community based maternal and child health services. The Sultanpur district also represents a mixed urban rural population where we can see disparities in health education, service utilization, and the availability of nutrition related information. As already I said that Anganwadi workers play a crucial role in delivering nutrition and health services under the Integrated Child Development Services program. So assessing their knowledge and practices in such a setting is considered essential for identifying the existing challenges and improving the effectiveness of maternal health interventions. So, considering all this in mind, the objectives that were framed for the study were to evaluate the knowledge regarding maternal nutrition among the Anganwadi workers in rural and urban areas in the Sultanpur city of Uttar Pradesh. The second objective is to examine the association between socio-demographic profile and knowledge regarding maternal nutrition among the rural and the urban Anganwadi workers. And our third objective was to assess the differences in knowledge on maternal nutrition among rural and urban Anganwadi workers in the Sultanpur district of Uttar Pradesh. Now, I would request Sneha Srivastav to continue with the presentation and tell you all about the methodology and the result and discussion part. Over to you, Sneha.
Thank you, ma'am. Next slide, please. A very good morning to each and everyone present over here. Myself, Sneha Srivastav, research scholar from Department of Family and Community Sciences, University of Allahabad. Today, I'm here to present a methodology as well as result and discussion part of the study. So, starting with the methodology section, the present study was a descriptive cross-sectional approach. The study was conducted in both rural and urban areas of Sultanpur district of Uttar Pradesh. The target population for the study were Anganwadi workers working in the ICDS scheme. In urban areas, at the time of data collection, 111 Anganwadi workers were recruited in the ICDS scheme. So, total of 111 Anganwadi workers were selected from urban areas. Since the rural population was comparatively large and geographically dispersed, inclusion of the entire population was not practically possible due to limitation of time and resources. Therefore, only 10% of the population was selected using proportionate sampling to obtain a manageable yet statistically significant results. Next slide, please. Talking about the data collection process, first of all, a formal permission letter was obtained from the district program officer for conducting survey. In the next phase, data was collected in the urban areas of Sultanpur city by interviewing and discussing different domains of maternal nutrition through Anganwadi workers. In the next phase, the data collection was extended to the blocks of rural areas of Sultanpur city. The statistical package for social sciences version 21 was employed for data entry and statistical analysis. Next slide, please. Now, I will discuss the socio-demographic profile of the respondents. Next slide. The findings indicate that a considerable proportion of the participants fell within the age group of 35 to 40 years, suggesting that the workforce was predominantly middle-aged. In terms of workplace distribution, most of the Anganwadi workers were posted in the rural areas, while 37% served in urban areas. Next slide. The educational profile of the respondent reflected a well-qualified sample holding graduate degrees, and most of them were Hindus. Next slide. Marital status showed that most of the Anganwadi workers were married and holds a 15 years of professional experience. Next slide, please. Talking about the knowledge score of Anganwadi workers. The knowledge of Anganwadi workers were assessed using a self-structured questionnaire reflecting the questions from different domains of services which they are providing to pregnant women for good health and well-being of the fetus. Next slide, please. These are the questions which I have made for assessing the knowledge of Anganwadi workers, and these are the responses of rural and urban areas. Like the first question is, does pregnant women need to go for antenatal checkup during conception? And majority of the correct response was from the urban areas of Sultanpur district. The second question is, first antenatal checkup should be done in first 3 months. And here also the majority of correct responses were from the urban Anganwadi workers. Next slide. Only in two questions the rural areas corrected correctly, like the should the blood pressure and pulse rate of women be checked regularly during pregnancy, and here the correct responses was mostly from the rural Anganwadi workers. And the next question is, should pregnant women undergo USG as advised by the doctor to monitor fetal growth? And here the correct responses was mostly from the rural Anganwadi workers. Next slide. These are the bar graphs showing knowledge score of Anganwadi workers. The bar graph indicates that the absolute number of correct responses appear higher in rural areas because the rural sample size was larger than the urban sample. However, when interpreted proportionately, urban Anganwadi workers demonstrated comparatively better knowledge score than their rural counterparts. This suggests that despite a smaller sample size, the awareness and understanding was relatively higher among urban Anganwadi workers. Next slide. Next slide. Now, talking about the association between socio-demographic profile and knowledge regarding maternal nutrition among the rural and urban Anganwadi workers. Next slide. This table shows the Pearson correlation between area of posting, that is rural and urban, and knowledge score regarding maternal nutrition during pregnancy. All the variables showed a positive correlation, which means better awareness was associated with the area of posting. The correlation were found to be statistically significant at 0.01 level because all p-values were less than 0.05. The highest correlation was observed for thus, screening for maternal nutrition risk factors and providing appropriate advice is one of the responsibilities of midwives, and daily consumption of IFA tablets and third trimester as primary time for fetal iron, fat, and calcium storage. Overall, the findings indicate that the area of posting has a significant association with maternal nutrition knowledge among Anganwadi workers. Next slide, please. Table 3 demonstrates a series of significant positive correlation between healthcare workers' posting status and their knowledge across key domains of maternal nutrition and antenatal care. Pearson correlation coefficient range from 0.142 to 0.486 with all corresponding p-values falling below the 0.05 threshold, confirming statistically meaningful associations. These results indicate that increased professional exposure and sustained field engagement are strongly linked to higher levels of understanding regarding essential maternal health components, including dietary requirement, micronutrient supplementation, and responsibilities related to antenatal risk screening. These findings highlight the critical role of targeted capacity building initiatives and continuous professional development in strengthening evidence based competencies among frontline maternal healthcare providers. Researches done in the past have also revealed that socio-demographic factors have a greater influence on the knowledge domain of Anganwadi workers. Next slide, please. Now we'll talk about the comparison of knowledge score on maternal nutrition among rural and urban Anganwadi workers in Sultanpur city of Uttar Pradesh. Next slide. This table compares the knowledge score of rural and urban Anganwadi workers regarding maternal nutrition using an independent sample t-test. The Levin's test showed a significant result indicating variation between the two groups. The t-test value was statistically significant. T-value is equals to 8.00. Differences in mean is 298 and p-value is 0.00. The mean difference between rural and urban workers was 5.24, showing a noticeable difference in knowledge score. Overall, the findings indicate that there is a significant difference in maternal nutrition knowledge between rural and urban Anganwadi workers. Next slide, please. This is the comparison chart showing knowledge score of rural and urban Anganwadi workers. The analysis revealed a statistically significant difference between the two groups, with urban Anganwadi workers demonstrating markedly higher knowledge levels compared to their rural counterparts. The mean difference of 5.24 point indicates a substantially higher level of maternal nutrition knowledge among urban Anganwadi workers. Here, you can clearly see in the chart that the urban Anganwadi workers showed a higher level of knowledge as comparison to rural Anganwadi workers. Next slide, please. The conclusion of the study is that the study underscores meaningful variation in Anganwadi workers' knowledge of maternal nutrition and antenatal care across urban and rural settings in Sultanpur city. The significant positive correlation between posting status and several knowledge domains along with higher knowledge scores among urban Anganwadi workers indicate disparities in training exposure and resource access. Overall, the study emphasized the urgent need for structured, continuous capacity building programs that enhance Anganwadi workers' competency in maternal nutrition and antenatal care, thereby improving the quality of community level maternal health services and contributing to better maternal and neonatal outcomes. Next slide. These are some of the visuals which I have clicked during my data collection process. These are the urban areas of Sultanpur city. Next slide. And these are the rural blocks of Sultanpur city. Here you can clearly see the Anganwadi workers responding to the questionnaire. Next slide, please. These are the references of my study. Next slide. Thank
Good afternoon, everyone. Today, I will discuss you the study, which is improving effectiveness of the infertility treatment and pregnancy outcomes in a woman using assisted reproductive technologies with an integrated approach to embryo selection. The study objective: enhancing pregnancy outcomes primarily depend on the ability to identify embryos with the greatest developmental potential, durably shortening in a time required to achieve pregnancy. Purpose of the study: a comprehensive analysis of the effectiveness of the modern embryo selection methods within the embryological stage of the ERT. The research methodology. The methodology of the work consists of a systematic approach and a comprehensive analysis of the result of the study of human embryos, followed by the statistical analysis of the obtained data. Morphological embryo assessment using stereomicroscopy and inverted microscopy. Continuously embryo monitoring with the embryo visor video monitoring system, Russia. Image visualization and embryo survival assessment, OCTAX image analysis system, IVR and vitro life. Preimplantation genetic testing using NGS sequencing. The main indicator of the embryo development were calculated in accordance with the Venn consensus report of expert meeting on the development of the ERT laboratory performance indicators, ESHRE, Special Interest Group of Embryology and Alpha Scientists in the Reproductive Medicine, 2017. Patient cohort. The study conducted in a EDK medical company between 20.
So first of all, thank you for the opportunity. Now I'm going to present my review article on medical treatment prior to micro-TESE. Okay. We know that non-obstructive azoospermia is the most severe form of male infertility, and micro-TESE with ICSI, intracytoplasmic sperm injection, offers these patients to become biological parent. However, overall the chance of sperm retrieval is not more than 50%. Therefore, medical therapy has been attempted to improve spermatogenesis. Sometimes it may lead to successful sperm retrieval during micro-TESE, and sometimes it may obviate the need of micro-TESE by leading to appearance of sperms in the ejaculate. So objectives of our review is to evaluate medical therapies used before micro-TESE, to assess the evidence regarding sperm retrieval success. Sorry for that. Just a minute. Sorry. I think that there is some issue. Okay. So first of all, these are, and then to assess the evidence regarding sperm retrieval success, we'll discuss the benefits, limitations, and controversies, and then we'll summarize the practical clinical implication points. I'll not go into details of nitty-gritty of spermatogenesis. However, for basic point, GnRH from hypothalamus stimulates the pituitary to release FSH and LH. FSH supports Sertoli cell and function and germ cell survival. On the other hand, testosterone plays an important role in later part of the spermatogenesis, that is beyond early meiosis, and FSH and testosterone act synergistically, and often their functions are overlapping, that is, lack of one hormone can compensate for another. So the patient selection, mainly 4 indications: hypogonadotrophic hypogonadism, then androgen excess, it may be because of exogenous sources, that is androgen abuse, or endogenous testosterone secreting tumor from adrenals or testicles. It may be hypergonadotrophic non-obstructive azoospermia or normogonadotrophic eugonadal non-obstructive azoospermia. If we see hypo,
Sorry
this
to
is the
interrupt,
only
Doctor.
condition.
Your slides are not moving.
Yeah.
Your slides are not moving.
Okay, sorry. Then just let me.
Can we share these slides on behalf of you? You can just say next slide.
Then it's better for me if you can please share it. Yeah.
Okay, doctor.
Otherwise, I think there is some technical issues. I really apologize for that. Yeah, so can you please move the slides to I think it's number 6, 7. Yeah, please move on. Yeah, keep this slide. Yeah. Next, please. Yeah. Just previous slide. Yeah. So hypogonadotropic hypogonadism is the only condition where there is no controversy regarding the medical management. It is characterized by low FSH-LH testosterone, often associated with testicular atrophy. It responds well to gonadotropin and sometimes pulsatile generis therapy. Therefore, spontaneous conception is possible and micro-TESE can be avoided in many cases. Next slide, please. Another issue is androgen excess. Okay, please. And no, previous slide. Yes, thank you. Another issue is androgen excess, where exogenous testosterone suppresses gonadotropins, or it may be endogenous. Please remember, there are certain men who are going to gym and they're taking testosterone supplementation for bodybuilding. And please remember, exogenous testosterone does not help improve spermatogenesis. Rather, it suppresses spermatogenesis because it creates the conditions like hypogonadotropic hypogonadism, because it creates the pituitary gonadotropins. Therefore, stopping androgen exposure may restore spermatogenesis. However, this may take even 2 years of time for pituitary to recover from the inhibitory effects of exogenous testosterone. Therefore, exogenous HCG and or FSH can accelerate recovery. And there is some evidence that clomiphene citrate may help stimulate endogenous gonadotropins. Next slide, please. If we see hypergonadotropic hypogonadism, where FSH-LH are already higher, people may ask, if already endogenous FSH and LH are higher, so how come you stimulate the testicles with exogenous FSH and LH? The theory is that if there is chronic stimulation by endogenous gonadotropin, it will lead to desensitization of Sertoli and Leydig cell. Therefore, the activity of endogenous gonadotropin will decrease, and it will lead to inadequate stimulation of testicular androgen. Therefore, if we supplement this main with exogenous gonadotropin, it will improve the serum testosterone level and improve the feedback inhibition of endogenous FSH and LH, leading to resetting of gonadotropin receptors, and in turn, it will stimulate the spermatogenesis. However, the evidence remains largely controversial. Next slide, please. Now, if we see normogonadotropic non-obstructive azoospermia, here there are certain changes in Sertoli Leydig cells. Therefore, the feedback inhibition from endogenous testosterone are reduced. And again, the frequency, pulse, and amplitude of endogenous gonadotropin secretion is reduced. And please remember, immunoreactive gonadotropin does not translate into bioactive gonadotropin. Therefore, this is the condition of relative or functional hypogonadism. Therefore, normal level of FSH is unable to stimulate the testes. Therefore, if we can overstimulate the testes, just like overstimulation of ovaries in case of IVF, it will lead to high concentration of intratesticular testosterone. Therefore, there will be good clone of germ cells that will be selected, and it will in turn improve the spermatogenesis. Therefore, this is the potential subgroup that can benefit from exogenous gonadotropin therapy. Next slide, please. So, gonadotropin therapy includes HCG, FSH, HMG, and recombinant preparations. As I mentioned, it is the treatment for hypo. Therapy is often prolonged for 6 to 12 months. However, evidence outside hypo remains largely inconsistent and controversial. Next slide, please. Now, GnRH therapy is a pulsatile therapy, a little bit cumbersome and costly, and patient has to take it through needle and sperm. It's effective in hypothalamic in a way where pituitary gland is intact. If pituitary gland is not functional, it will not act. Therefore, you can avoid micro-TESE because spontaneous conception is possible. However, there is limited role of GnRH therapy in idiopathic non-obstructive azoospermia. Next slide, please. Now, coming to aromatase inhibitors like letrozole and anastrozole. In infertile men, often estradiol concentration increases and testosterone reduces. Therefore, aromatase inhibitors are useful in men with low T2E2 ratio, particularly obese men and Klinefelter syndrome. However, it is not yet approved by FDA for use in non-obstructive azoospermia. Next slide, please. Now, ACRM, selective estrogen receptor modulators like clomiphene citrate or tamoxifen, particularly useful in low testosterone cases, but remember they are useful if estradiol concentration is normal but testosterone is low. However, evidence is anyways limited and there is no consensus regarding dose and duration of these medicines. Next slide, please. Now, if we review the evidence, hypo, it is a treatment, there is no doubt, no controversy. TESE is rarely required, only required when hormone therapy fails to improve spermatogenesis. Often they require prolonged treatment and natural conception usually occurs. Next slide, please. Now, if we see hypo cases and hypergonadotropic hypogonadism, mixed evidence, mainly retrospective studies. Some studies showed improved sperm retrieval rate, others did not show the same thing. High quality randomized trials are lacking. On the other hand, in eugonadal men, the evidence is more robust than in hypogonadal men. That is, hormone therapy works better in eugonadal men. That is, if you have normal testosterone, normal FSH rather than high FSH, some men can develop sperms in the ejaculate, by which you can avoid micro-TESE. Methodological heterogeneity is there because most of the studies are yet retrospective. Next slide, please. Now, risk and adverse event. Gonadotropins can lead to gynecomastia, injection site reactions, but mild reaction. Aromatase inhibitors sometimes can lead to reduced libido because estradiol is essential for male sexual function and it can cause bone weakening, osteoporosis. ACRM can cause visual symptoms, particularly tamoxifen can increase the risk of thromboembolism, which is relevant in men with Klinefelter syndromes, and long-term safety data remains limited. Next, please. Now, sometimes men with failed micro-TESE, that is micro-TESE was done, but it failed to retrieve any spermatozoa. In that cases, hormone therapy may improve repeat sperm retrieval outcome. But however, the sperm retrieval success rate can vary, but it was trying hormone therapy before you attempt next micro-TESE. Some cases, micro-TESE hormone therapy may convert azoospermia into cryptozoospermia, that is, sperms may be found in the ejaculate. However, again, evidence is limited and most of the studies are retrospective. Next, please. So this is our recommendation. Hypo, usually micro-TESE is not needed. HCG and FSH are a treatment, and in some cases, pulsatile GnRH therapy can be attempted. If androgen excess, usually micro-TESE is not needed. Stop exogenous androgen. Consider HCG, consider clomiphene, and if it is because of congenital adrenal hyperplasia, consider glucocorticoid. In other cases, like idiopathic cases, we can consider micro-TESE, but with adequate counseling and explanation of the limitation of available evidence. If it is hypergonadotropic condition, HCG and or FSH should be considered. If it is normogonadotropic, then see the testosterone level. If it is normal, eugonadal, consider FSH. If it is low, then consider FSH or HCG and check testosterone to estradiol ratio. If it is low, that is less than 10, consider aromatase inhibitors. If it is high, then consider ACRM like clomiphene or tamoxifen. Next slide, please. Therefore, careful endocrine evaluation is mandatory as well as genetic testing. Like you can't use hormone therapy in men with Y chromosome microdeletion A and B because you can't stimulate those testicles. Therefore, patient selection makes sense. Therapy may reduce the need for surgical sperm retrieval and it needs counseling, and timelines is essential because if otherwise, like there is severe female factor problem like low AMH or female age is say around 40, you can't waste time trying hormone therapy months after months. Next, please. Therefore, in a nutshell, medical therapy has established benefit in case of hypo. Role in other forms remains controversial. Quality of evidence is limited. Therefore, we need further randomized trials to see whether hormone therapy can play important role in case of non-obstructive azoospermia, particularly before attempting micro-TESE. Thank you very much for your patient hearing.
I am Dr. Aditya Pillai. I am working as research scientist in cytogenetic division of Central Research Laboratory, Believers Church Medical College Hospital. This study is actually a pilot study which we done in our research laboratory. Evaluation of genotoxicity in infertile patient. Next. So, as we all know, like most of the audience are from this background, so we know that the infertility, the impact of infertility is putting in the society. So, because it is affecting millions of couples worldwide, and it is actually becoming a major reproductive health problem, affecting nearly 10 to 15 percentage of couples worldwide. And in that also, male infertility is something very, it is in the limelight, because in the let's say say for example 10 year or 20 years back, more female infertility was on the talk, but now the talk is more on male infertility. And genetic environmental factors are contributing significantly. So in that, oxidative stress and DNA damage is something which we are focusing on. Next slide. Yeah. So genotoxicity, as we are dealing with the genotoxicity area, so our aim is to look into more genotoxicity in infertility. So basically, this genotoxicity refers to damage to the genetic material of cells, which is DNA. So it can be a strand break, or it can be chromosomal abnormalities, mutations, or some other, genotoxic biomarkers causing instability. So, such damage can actually impair in all the way. For example, in infertility, it can impair gamete quality, fertilization, embryo development, implantation. So, ultimately leading to reproductive failure. So, several biomarkers are there to assess this genotoxicity, in which micronuclei formation, nuclear buds, nucleoplasmic bridges were commonly we have evaluated in this study. Next slide. So why DNA damage and infertility? So as we all know, there is an increased amount of oxidative stress, as like your previous presentation, Dr. Das Gupta, he said that there require a, like a minimal amount of oxidative stress for this spermatogenesis. So definitely, but there is an increased oxidative stress in infertile patient. So DNA fragmentation is happening there, genomic instability is there. So overall, but this genotoxicity assessment is we feel that somewhat it is not focusing to the point. Next slide. So I think we all know the major cause of genotoxicity. Need not to explain this slide. So major things are reactive oxygen species and all the lifestyles, infection, occupational exposures, and all. So there, like from all the aspect, ultimately it can lead to genotoxicity. So we'll quickly move on to the like what exactly we have done. Next slide. So basically, we have focused on DNA strand breaks, micronuclei formation, chromosomal aberration, oxidative stress markers, and see, sperm DNA fragmentation index is something which all the ART centers are doing. But looking the genotoxicity from the blood is something very rare. I don't think, like, at least in centers in Kerala they are focusing on blood genotoxicity. So next slide. So our study design was actually a case control study, infertile versus healthy, and we have collected blood sample, heparinized blood sample. So this pilot study was conducted to evaluate a systemic, genetic instability in OATS patient, athenoteratozoospermia patient. So patients and all the patients who visited the OPD of our reproductive medicine department. So main methods we focused were on COMET assay and CBMN assay. Next slide. Yeah, so Next slide. Yeah. Yeah, so this is just a pictorial representation of the workflow. So as I told you, we have mainly focused on two assays, that is Comet assay and CBMN assay. So Comet assay is a single cell gel electrophoresis assay which focus on or which tells you the amount of DNA breaks, and CBMN assay is something which tell you all the genotoxic biomarkers like micronuclei, nuclear bridge, nuclear bud. So for all these, we have taken 2 ml of heparinized blood from the sample, and this both assays are 2-day procedure. And after that, we have compared it with statistical. Next slide. So our results were first visual observation of DNA damage. So qualitative assessment of DNA damage was performed using fluorescence microscopy. So this Comet says result have to be seen through fluorescence microscopy, and this is what we have observed. So you can see the topmost left side one is normal DNA. So basically this assay will tell you if your DNA is damaged, your cells will look like comet, so a head with tail. And if you have a normal DNA, it will the cells will look like just as the circular ones. So you can see the left side below one, that is which is written as moderate DNA damage. You can see the head and tails of so that much extent of DNA damage is there. And in the positive control also, you can see the tails are the length of tail is something. Yeah, oh, okay. Can you just move to next slide? Yeah, so I was talking about these figures. So can you see? So it is written normal DNA, mild DNA damage, moderate, and positive. So if you have a DNA damage, your cells will have a head and tail. So you can see moderate and positive. So this is figures which we see under the fluorescence microscope results of same, and we have seen that OATS patients are having DNA damage in between moderate and mild. So, next slide. Yeah, so this is the result distribution variables of oats and healthy. So the p-value for mean comet length we got 0.02, and tail length we got 0.001, and for both tail length in micrometer also 0.001. So you can see that in oats patient the maximum comet length is 49, and whereas in healthy it's 32. So yeah, so in here healthy is also having, because there are other environmental factors of having genotoxicity, but you can see compared to healthy, oats patients are having more. And in case of tail length also, they are having 67.5, whereas healthy is having only 28.5. And in micrometer tail length also it is 22.3, whereas healthy is having 9.4. So which shows a more tail and comet length in oats patient compared to healthy. So next slide. Yeah, so the primary objective here was to evaluate systemic DNA damage using alkaline comet assay by measuring this comet tail length. And so this is the graph which we got for comet length. You can see oats patients are having more comet score than healthy controls. So the oats patient exhibited significantly higher median of comet length of 49.0 pixels, whereas compared to 32.9. So this is the mean comet length. Next slide. So yeah, so the topmost graph shows the distribution of maximum tail length in micrometer with oats patient compared to healthy, and the below graph shows the maximum tail length in oats patient and healthy country. So this distribution of maximum tail length in pixels. So you might be you may be in a confused state that why I have used both micrometer and pixel, because the software which we use, it gives the result in tail length in pixel, and we actually convert the pixel into micrometer to be more precise with our results. So these are the two graphs. You can clearly show that oats patients are having more tail length compared to healthy controls. So next slide. Yeah, so this is the result of CBMN. So CBMN is cytokinesis block micronuclei assay, where you will see the number of micronuclei, nuclear bridge, nuclear bud. So we have done again the CBMN compared with oats and healthy. So CBMN, we have actually taken two group of patients who were having mild DNA damage and moderate DNA damage. So in that you can see the below table which shows so we have calculated 1,000 binucleates. So our measurement is like the number of micronuclei per 1,000 binuclei. So you can see 43.23, and nuclear bridge is 10. So you can see the minimum and maximum. So mean was 43.23, whereas maximum micronuclei was 57. By like in 1,000 binucleate we have seen 57 micronuclei. 22 was the maximum number of nuclear bridge. 10 was the nuclear maximum number of nuclear bud. So this all shows that there is a higher genotoxicity biomarkers in oats patient. Can you just move to next slide? So as I told you, this was a very pilot study, and so this we are actually doing a this same study on a larger cohort with other biomarkers also. But the conclusion for our this pilot study was it demonstrated a significant increase in comet tail length and in healthy group versus the oats patient, which shows an early genotoxic effect attributable to cumulative oxidative stress. So here we have actually our aim was to see that whether this systemic oxidative damage or oxidative stress is actually reflecting the sperm DNA fragmentation, because in many of the IVF centers, ARTs, they are actually going for this sperm DNA fragmentation, but none of them are going for these kind of basic assays to see the systemic oxidative stress. So our main aim was to actually see that whether the systemic oxidative stress can reflect your reproductive health. So these findings indicate that the primary driver of genomic instability in oats is not necessarily increased oxidant production or lipid peroxidation, but rather the loss of antioxidant buffering capacity also, which is already proven. So this redox imbalance creates a vulnerable cellular environment which relatively increases in reactive oxidant species and leading to DNA strand breaks and impaired repair mechanism. So next slide. So, clinical significance is early detection of reproductive DNA damage. So, rather doing a DNA sperm fragmentation assay, you can actually first go for a systemic oxidative stress assessment from your blood also. Then personalized treatment strategies, prevention through lifestyle modification, then integration of molecular biomarkers in fertility clinics. Then there are AI assisted analysis of genotoxicity data. Large scale longitudinal studies has to be done, and we are actually doing a large cohort study which we have started last year. And targeted antioxidant therapies, which almost all like most of the ART centers are now following. So next slide. Our possible policy implication for this study can be incorporation of genotoxicity screening in infertility evaluation, like introducing CBMN and comet-TESE, which are very basic assays, which even the small labs can do. So, especially for like it can act as a supportive diagnostic tool. So, we actually stress this word of supportive diagnostic tool, because we are not saying to stop all what you are doing, but we are just saying you can incorporate this to your routine things, just to kind of a patient support. And then establishment of reproductive genotoxicity monitoring programs. You can actually create a hospital based monitoring for all these environmental exposure risk and all. Then lifestyle and environmental health policies, like your findings can actually aim to reduce exposure to genotoxic agent. Then all these anti-smoking initiative by these reproductive centers, then occupational safety regulations, or making aware patients, like okay, suppose a couple is coming to you and they are, if suppose they are working in some oil mining or petrol pumps, or they are dealing with some fertilizer company or something, so you can make them aware to like what you can do for these all, because public awareness is something which is more important. Next slide. Yeah, so these all are references. Next slide. Yeah, so these are some of our small outcomes from these studies. So we have some of the publications, and we actually represented this in one of the international conferences which happened in India. And there are some few thesis dissertations also out of these studies. So we are mainly focusing on genotoxicity in male infertility. Yeah, so next slide, last slide, thank you slide. Yeah, so can you just, yeah, so this, I just wanted to show you, this is our Believers Church Medical College Hospital where we are actually doing this study. Yeah, so thank you so much. Thank you, Gynecology Summit 2026, for giving me this opportunity.
My presentation is on the rapid versus conventional preparation in the preparing the patients pre-operatively in the for the Graves' disease thyroidectomy. It is a randomized controlled trial. So, why the patients in the Graves' disease patients? It is the most common cause of the hyperthyroidism. About 50 to 80% of the cases, and it is an autoimmune disease caused by the high level of thyroid receptor antibody, which increases the thyroid hormone synthesis. And there are three modalities of treatment: antithyroid drugs, and the definitive treatments include radioiodine and surgery. Surgery is indicated in the patients with large goiter, having orbitopathy, malignancy suspicions, antithyroid drug failures, and the patient preference. So conventionally, we use antithyroid drugs, methimazole, carbimazole, and propylthiouracils, which takes a mean time of about 3 months in the patient to achieve euthyroid before surgery. These drugs in about 3 to 7% of the patients may have adverse effects, and the patient may need multiple hospital visits and multiple time thyroid function evaluation. So, and in less than 1% of the patients may have a risk of agranulocytosis. In the rapid multimodality preparation, we include conventional antithyroid drug. Along with, we use Lugol iodine, which decreases gland hormone synthesis as well as secretion and gland vascularity, dexamethasone, which inhibit peripheral conversion, and propranolol, which inhibit peripheral conversion, along with adhesions effects. So these three forms of treatment help to achieve have their onset of action within 1 to 2 days. And with the help of this, we can achieve euthyroidism within a week. So the question is rapid multimodality preparation is non-inferior to conventional antithyroid drug preparation in terms of perioperative safety, surgical difficulty, and post-operative outcomes. So primary objective was the time taken in normalization of thyroid function test, and the other secondary objectives were the intraoperative physiology, thyroid difficulty during surgery, parathyroid visibility, postoperative hypocalcemia, voice changes, hospital stay, calcium supplementation needs, cost effectiveness, and hospital visits. So methodology, this study is a randomized controlled trial, single center open label study, duration from December 2019 to December 2021 in the endocrine surgery department, KGMC, India. It is was randomized with the 20 sealed envelope method, and each arm each patients have to pick an envelope before starting before the enrollment. So the sample size, there were 10 patients each arm, the power to have the power of more than 80%, and alpha value 0.05. Was ethically approved. So inclusion criteria includes the patients having Graves hyperthyroidism, Graves disease diagnosed with the thyroid receptor antibody test, and the patients having surgical indication according to American Thyroid Association 2015 guidelines. Patient who refuse consent and having comorbidities, having drug allergies, and thyroid function test non-normalization within protocol period were excluded. So the consort diagrams, 31 patients were assessed for eligibility, 3 patients denied consent, 3 were having the comorbidities, and 2 patients had the drug allergy. So 23 patients were randomized, 12 in the group A and 11 in the group B. So the 2 patients lost to follow-up in the conventional group, and 1 patient was not able to achieve euthyroidism in a week in a rapid preparation group. So the results, all the baseline parameters, the age, sex, BMI, clinical activity score, and the mean thyroid hormone levels were comparable in the 2 groups. The time to normalize in the conventional group ranges from 6 to 12 weeks, the mean of 9 weeks. And in the group B, 10 out of 11 patients were euthyroid by day 7. And the 1 patient achieved euthyroidism by the day 12. So we included just 10 patients in the further assessment who underwent surgery and were assessed. The simultaneous suppression of all the 4 axes of thyrotoxicosis in the rapid preparation, that is the hormone synthesis, release, conversion, and the adgenic axis, but blocked. That may be the reason for this rapid euthyroidism. The intraoperative physiology, safety, the heart rate, means systolic blood pressure, the core temperature, ECG rhythms were comparable in the 2 groups. The non-patients have thyroid storm and intraoperative crisis. The thyroid difficulty score is a subjective score by the operating surgeon. Score 1 to 5 for each variable, that is vascularity, gland friability, the gland mobility, and the gland size was scored. The score improved in the rapid preparation with the total thyroid difficulty score 4 and 3, 4 in the conventional group and 3 in the rapid preparation group. This observation might be due to the Lugol iodine given in the rapid preparation group, which decrease the gland vascularity, make it more firm and mobile. The gland size were comparable in the 2 groups. The mean parathyroid visualization score was 2.4 in the conventional group and 3.1 in the rapid preparation group, which was statistically significant. The more gland visualized, we have a greater opportunity for the gland preservation and autotransplantation, and it is the strongest modifiable intraoperative predictor of postoperative hypoparathyroidism. So likely mechanism, there is a decreased gland vascularity because of the Lugol effect, and decrease and improve the operative field clarity and the parathyroid gland visibility. The patients in the conventional group have 40% and the rapid preparation group has 30% of hypocalcemia, but it was not statistically significant in the statistically significant, but maybe clinically significant. So other intraoperative parameters, that is a gland weight, size, operative times, and the blood loss were comparable in the 2 groups. The postoperative clinical hypocalcemia, seroma, the voice change, hemorrhage, or the brain removal day and hospital stay were comparable in the 2 groups. So the cost of the antithyroid drugs and the thyroid function test cost was significantly less in the rapid preparation group. Other things, surgery and the pre-op investigation, post-op monitoring investigations, and the calcium drug expenditure were less in the rapid preparation group, but was not statistically significant. Only statistically significant was the cost of antithyroid drug and thyroid function test cost. So in the rapid preparation group, near about 2,000 rupees less per patient in expenditure. So it was more economical in the rapid preparation group. So in discussion, no prior randomized control trial have happened with assessment, intraoperative assessment of the thyroid difficulty, and the Lugol iodine not only improve the patient just biochemically, but also responsible superior surgical field. And in-patient protocol of doing rapid preparation eliminate loss to follow-up during the optimization, and economical advantage is relevant in the resource-limited healthcare systems. The limitation was a small sample size, which make it underpowered to evaluate for the thyroid storm and the permanent hypoparathyroidism. And it was an open label study, so thyroid difficulty scoring may have observation bias. It was a single center study, and the post analysis was in the Indian public sector context, not directly comparable to the higher income settings. And the Lugol iodine require fresh preparation and require special storage. And our study has a short follow-up of 6 months. So conclusion, rapid multimodality preparation for Graves' thyroidectomy is a safe, cost-effective, and surgically superior alternative. Thank you.
Good afternoon, everyone. So I am Dr. Shashikala Gurappa Hiremani, Head of the Department of Pathology, and I am from Taluka General Hospital, Basavan Bagiodi, District Vijaypur. And 1 year back, I was working in District Hospital Vijaypur as a Head of the Department of Pathology. So today I am here to present a topic on atypical presentation of follicular thyroid carcinoma, a rare case report. So you can cite this article at Hiremani SG, atypical presentation of follicular thyroid carcinoma, a rare case report, and innovative publication of Diagnostic Pathology and Oncology Journal in the 2025 10 issue and 1 volume, and page number 45 to 48. So it is also available in the following website also. So coming to introduction, about 10 to 15% of all the thyroid tumors are follicular thyroid carcinomas. It is the second most prevalent kind of differentiated thyroid cancer. Typically manifests in the 5th and 6th decades of the life and is more common in women. Below 45 years of age, the incidence lies below 1% of the patients. It frequently invades the blood vessels and spreads simultaneously to distant locations, usually the lungs and bones. According to reports, the frequency of the distant metastasis in follicular thyroid carcinoma ranges from 6 to 20%. Early detection, timely intervention, and regular follow-up plays a crucial role in improving the prognosis and prolonging survival in FTC patients. About 80% of the patients diagnosed with any subtype of differentiated thyroid carcinoma responds to total thyroidectomy, levothyroxine, and radioiodine 131 ablation. However, unlike PTC, follicular thyroid carcinoma often presents with benign appearing features on ultrasound, leading to potential misdiagnosis as thyroid follicular adenoma, which complicates treatment decisions. Pine needle aspiration also has limited diagnostic accuracy due to the lack of specific cytological markers for follicular thyroid carcinoma. Diagnosis is typically confirmed through histopathological examination, emphasizing vascular and capsular invasion. However, inadequate sampling or the absence of clear invasion foci can result in missed diagnosis. Consequently, a combination of morphological assessment, immunohistopathological analysis, and molecular pathology is often necessary for accurate diagnosis. This presents a case of a patients with follicular thyroid carcinoma exhibiting cervical lymph nodes metastasis, no distant metastasis, diagnosed exclusively through the fine needle aspiration cytology. This study was done according to the care guidelines at District Hospital Vijaypur in the month of March 2025. A 45-year-old female presented with a diffuse swelling over the neck since 2 years. So I'll show you in the figure 1. Initially, the swelling was left side of the neck, measured 1 × 1 centimeter, but had progressively increased in size over the past 30 days, reaching present size of 6 × 4 centimeter, diffusely involving the right side of the neck also. The swelling had previously been asymptomatic, but the patient recently developed difficulty in swallowing. There was no history of fever, weight loss, or the heat intolerance. On clinical examination, the swelling measured 7 × 5 centimeter, involving both the lobes of the thyroid, left lobe swelling measuring 4 × 3 centimeter, right lobe swelling measuring 3 × 2 centimeters, both hard in consistency and were mobile with the degglutination and no local rise in the temperature. Left and right cervical lymphadenopathy were present. Largest was measuring left lymph node measuring 3 × 2 centimeter and it was hard in consistency. So this is a figure 1 showing the patient presented with the diffuse neck swelling. Investigations, we did a thyroid function test which revealed the normal results. So patient was subjected for the neck ultrasound, demonstrated an enlarged left lobe thyroid measuring 4 × 8 × 3.6 × 4.4 centimeter with a hypoechoic nodule measuring 3.8 × 3.2 centimeters, completely replacing the thyroid parenchyma and containing the macrocalcifications. Enlarged right lobe of thyroid measuring 3.0 × 2.6 × 2.4 centimeters with a hypoechoic nodule measuring 1.6 × 2.0 centimeter with 4 colloid nodules of each measuring 0.4 × 0.5 millimeter in size. Few enlarged left and right cervical lymph nodes, level 2, shows central areas of necrosis. However, there was no conglomeration noted. Final aspiration cytology we did, and it was performed in the Department of the Pathology, District Hospital Vijaypur, on left lobe of thyroid, right lobe of the thyroid, and largest left cervical lymph node swelling. The fine needle aspiration from the left-sided thyroid lobe swelling yielded blood mixed material. From right lobe swelling produced pale brownish thin colloid like material. From largest left cervical lymph node also aspirated scant mixed material. Microscopic findings from the left lobe of the thyroid swelling revealed hypercellularity with micro and macro follicular small clusters arrangements. Cells were pleomorphic with high NC ratio showing 2 to 3 nucleoli and nuclear overlapping. The cytoplasm was scant with the irregular borders seen in a no colloid and necrotic background as in figure 2 and A and B. So this is the figure 2 showing, and it was stained under Magog Jim's stain, and we studied under 10x. FNDC slides at the left lobe of the thyroid swelling. Atypical follicular cells, they are arranged in the small clusters and the small follicles. And right side, you can see there is a this slide was studied under the high power, and cells are showing with the high NC ratio with a prominent nucleoli with a no colloid in the background. Final aspiration cytology microscopic findings from the right lobe of the thyroid swelling shows small clusters and microfollicular cells arrangements with marked cellular pleomorphism with a high NC ratio with a scant amount of cytoplasm. Background shows scant amount of colloid. Yes, shown in the figure 3. This is the figure 3, and it is stained by Papa-Nicol stain and studied under 40x, showing atypical follicular cells with a high NC ratio with a prominent nucleoli with a scant amount of colloid background. Microscopic findings from the left cervical lymph node demonstrated similar findings as that of left lobe of thyroid swelling, and you can see in the figure 4. And this is the figure showing cytology slides of the left cervical lymph node showing atypical follicular cells with a high NC ratio, prominent nucleoli. And we diagnosed with the features suggestive of the follicular thyroid carcinoma. Coming to discussion, follicular thyroid carcinoma is a well-differentiated thyroid malignancy that prominently spreads through the hematogenous routes rather than the lymphatic pathways. Nodal metastasis from the follicular thyroid carcinoma can occur in a variety of ways. According to estimates, nodal metastasis range from 4.7 to 30%. Unlike papillary thyroid carcinoma, follicular thyroid carcinoma lacks distinct nuclear features and specific cytological markers, making its diagnosis challenging. In this case, the patient had long-standing left-sided thyroid swelling with rapid enlargement in the past 30 days, accompanied by the development of a right-sided neck swelling and cervical lymphadenopathy, raising the suspicion of malignancy. Despite normal thyroid function test, ultrasound findings of a hypoechoic nodule with a complete parenchymal replacement and macrocalcification suggested the malignancy. FNEC study also confirms features consistent with the malignancy. Follicular thyroid carcinoma is often difficult to distinguish from the follicular adenoma based solely on the cytology. As a definitive diagnosis requires histopathological confirmation of capsular and vascular invasion. However, in this case, the presence of lymph node metastasis along with the acute course of increase in the size of the swelling is strongly supported a malignant diagnosis. Although follicular thyroid carcinoma predominantly spreads hematogenously, regional lymph nodes involvement has been documented in a small percentage of cases as similar to in our case. This case highlights the importance of the integrating clinical, radiological, and cytological findings for early diagnosis and appropriate management. Surgical excision followed by histopathological examination remains the gold standard for the confirming the diagnosis and determining the further treatment, including the radioactive iodine therapy if necessary. Coming to conclusion, follicular thyroid carcinoma remains a diagnostic challenge due to its overlapping features with the benign follicular lesions and its reliance on histopathological confirmation for definitive diagnosis. This case underscores the significance of comprehensive diagnostic approach combining clinical evaluation, imaging, and cytological findings, especially in the presence of a atypical presentation such as lymph node metastasis. Early diagnosis and prompt surgical management are the critical for the improving the patient outcomes. These are my references. Thank you.
Optimizing care pathways, a twin pregnancy audit, enhanced maternal and neonatal outcomes. It has been done on 2024 to 2025. So the background shows that fertility treatments and increasing maternal age means that multiple births are becoming more common. NICE guideline was released, which was updated on 2019, and between the 1st of December 2024 to 30th of November 2025, there were 83 twin pregnancies scanned in this hospital, and the medical record were obtained from the hospital record books, and data was collected on auditable principles as per NICE guidelines. So what was the aim of the audit? To compare the management of multiple pregnancies booked at that district level hospital between this time frame. And it was compared with the NICE guideline in terms of the booking, the antenatal care, and delivery. So we all know about the NICE guideline, twin and triplet pregnancy. I'm just skipping this guideline, and then we will be going to the main audit part. So we identified the 83 cases and the hospital record books, as I said before, and 3 cases were transferred care or lost to follow-up, and paper notes were not reviewed. So it shows that about 2.55% were less than 20 age ladies, and 20 to 30 years old were 37%. And among the twin pregnancy, the maternal age was 30 to 35% in 30% cases, and more than 35 years old are 25% cases. And if we see the BMI, the significant BMI was 20 to 25 in 35% of women. So what are the types of twin pregnancies we have noticed among these 83 ladies? So 58 cases were DCT-A twin, that is the dichorionic diamnionic twin, and 17 was monochorionic diamnionic twins. There was only 1 case of MCMA twins, and 7 cases we lost the data. So about the risk factor for aspirin, the multiple pregnancy is a risk factor for aspirin. So 45 women were identified to have at least 1 additional risk factor for aspirin on booking, and 5 identified to have more than 2 additional risk factors for aspirin, like including the first pregnancy, previous PET, high BMI, age more than 40, chronic hypertension, and previous stillbirth. As per the guidance, 39 women were eligible for aspirin, and for 35% of these women, there was no documented record of them being on aspirin. So the mode of conception for this twin pregnancy ladies are spontaneously 72 ladies, and they had the Clomid, and it was 9 ladies, and 1 lady came in with the IVF pregnancy who had the multiple pregnancy. The outcome of the pregnancy was both of the babies live in 72% cases, both IUD, unfortunately, in 1 case. 1 lady miscarried less than 24 weeks, and there were no data for 2 ladies. So during the booking, the gestational age was less than 10 weeks in 72% cases, and 28% cases we have seen them in more than 10 weeks. Antenatal screening, we have done the down screening and anomaly screening. The growth scan was done in case of 91% cases, and no growth scan was done on 9% cases. Antenatal complication were there, and most important complication we have found is the anemia in 25 ladies, and also we have found GDM in 12 ladies. The other complications including APH, essential hypertension, hyperemesis, hypothyroidism was there. And the timing of delivery, mostly the DCT-A twins continue the pregnancy till 37 to 38 weeks in 16 cases, and in less than 37 cases, in less than 37 weeks of gestation, 42 women delivered. And in MCDA cases, we have seen the pregnancy up to 36 to 37 weeks in 4 ladies, whereas it's below 36 weeks in 13 patients. The mode of delivery, as I explained before, the 4 cases of spontaneous vaginal birth and then cesarean section. There are various indications of the cesarean section for FEH, the cord prolapse, severe PET, and failed ECV for transfer slide. And indication of the emergency cesarean section. Among all these 83 ladies, 26 cases had the emergency cesarean section. There was the transfer slide, the APH, severe PET, pre-prom, fetal compromise, and in 3.8% cases, we have seen the interlocking twins. There were some fetal complication, and the babies needed the SCIBU admission in case of 19.6%. And there were the low IUGR in both of the babies, polyhydramnios, prematurity, selective IUGR, etc. So what were the limitations of when we did the audit? During this audit, we accessed the hospital records only and did not have access to the paper notes. So therefore, lots of interpartum data was not available to us. The results showing only 65% of women eligible for aspirin as per NICE guideline documented to be taking it. Anemia is the commonest pregnancy complication, as I mentioned before, affecting the 30% of the pregnancies, and prematurity is the commonest fetal complication, affecting the 66% of the twin pregnancies. So what went well? Majority, like 72% of women booked before 10 weeks. Majority of the patients received the antenatal down screening. 100% monogynous pregnancy had the serial growth scan. And the intrapartum policies like CTG monitoring for multiple pregnancy updated according to NICE guidance 2019. So what are the issues we identified are few patients didn't receive aspirin, though they are eligible for aspirin. Anemia, the commonest antenatal complication. Number of the prematurity are high. Number of emergency cesarean and delivery of second twin by cesarean is high. Fetal compromise is the commonest cause of emergency cesarean section. However, only few babies needed the NICU admission, like 19.6%. And as I mentioned before, the missing of few documentations. So what were the recommendations from this audit? So we need to offer aspirin if patients are eligible for that. Re-evaluation of for aspirin if twin pregnancy is diagnosed at booking. We need to check the anemia at booking, 20 to 24 weeks and 28 weeks as per the NICE guideline. And we need to offer iron if low hemoglobin as per NICE guidance. Maternity department should have named lead nurse and named lead sonographer for the multiple pregnancy as per NICE guidance. Diligent documentation is needed. Thank you very much. Thank you for patience hearing.